My name is Rochelle, and this project is a quality improvement project talking about how we try to improve the G-tube education process for parents that were going home with babies in the NICU with G-tubes. And it took us about 2 years to get to this point in order to get a good number of patients. Um, Okay, so I did have a big team of people helping me here, and that included residents, practitioners, hospitalists, nurses, nurse practitioners, and we did this under the Quality Champions program in 2024 that gave us a lot of guidance. We also coordinated with the general surgery team in addition to the NICU team to get this project going. The background of this is we realized that our education process lacked standardization. Everybody taught a little differently in terms of the material and who was teaching what. We realized that we could use different tools to help us with this education. We wanted to make sure we were addressing disparities and barriers such as language barriers that might be at play when providing education. And then we wanted to improve the coordination across teams to make sure that this education was a streamlined process. So here we see our driver diagram. So with the primary drivers being the need to standardize, the need to get multidisciplinary education, track compliance, as well as provide family-centered care, we then came up with the following change ideas. So we started by just looking at all of the literature on what constituted safe G-tube care. We then created this pathway incorporating those steps. We defined roles and responsibilities for each provider, for nurses, for surgeons, for ourselves, for who would teach what and in what timeline. We had subsequent PDSA cycles to see what changes would be impactful to this process. And then we did try to include our parents' feedback by providing a survey on the telephone after they went home to ask them both for quantitative and qualitative feedback on the GTube education process. Our SMART aim was that we wanted to see a 20% increase in parent satisfaction score over a 2-year period ending in January 2026. To achieve this, the process measure we tracked was completion of the 5 steps of the GTube education pathway, with the goal being that at least 80% of those steps be completed before discharge. We did provide for outcome measure a parent follow-up questionnaire where they were given a 5-point survey asking how they felt about their GTube function, did they feel confident and satisfied, and also asking for qualitative feedback for ways they think we could improve our process. We checked post-discharge weight gain using Z-scores to see how babies fared in terms of nutrition after going home. And as a balancing measure, we looked at this post-discharge resource utilization for the first 60 days for both total resources as well as GTube related resources, including phone calls, messages on the app, ED visits, clinic visits, and hospitalization. So this is what our pathway look like. We start first with an encounter with the general surgery team who meets the family and talks to them about why their baby is getting a G-tube, what the surgery looks like, and what common complications of the G-tube surgery can be, as well as complications to watch for after they go home and how to manage those complications, such as what to do if the G-tube came out, what to do if the G-tube got blocked. After this encounter, usually soon after the surgery was done or at the same time, parents were given the opportunity to watch videos. They could do this on their phone or they could do this on the computer in the room. And the videos gave them the opportunity to watch at their own pace and their own time the information about G-tubes in children. Once the baby had been stable for a few days, usually 2 or 3 days, we started hands-on teaching, which is our nurses meeting with the families and showing them the different steps on how to feed the baby and how to take care of the G-tube. We also used a tracking sheet to demonstrate trials as well as for parents to demonstrate those trials back to us, so sort of using a teach back. And this gave the parents an expectation of how much education they had to complete. And they were given a written care plan in their own language, Spanish, English, and Haitian Creole, where frequently asked questions were answered and phone numbers were given to reach for help after they went home if they had questions about their G-tube. Um, then, close to discharge, the representatives of the DME companies who provided the G-tube supplies would come by to teach them about home equipment. And lastly, just before discharge, the discharging team would review the discharge care plan, update any changes that needed to be made, as well as reiterate how the family could reach out for help if they needed help after they went home. And so, coming to our results, over the 2 years, we had 33 patients in our NICU that had G tubes placed, of which 28 we were able to get follow up information. A few of them would died, unfortunately, or transferred out, or a couple are still admitted, so we don't have follow up on them yet. As you can see, a good number, about 67% of these babies were preemies, which also meant that they had significant other morbidities in addition to just needing the G tube. About one-third of the patients had craniofacial anomalies. One-third had severe lung disease, what we call BPD. So they also had tracheostomies. And then one-third had severe neurological disease, such as hypoxic brain injury, severe hypotonia, or dysphagia. And so this was the primary indication for the G-tube in the cohort of patients. As you can see, the patients were quite young. On an average of the mean chronological age at discharge was 5 ±3 months. And majority of our patients were on Medicaid, about 76%. 73% spoke English, but about 18% spoke Spanish and 9% spoke Haitian Creole. And so here we see a run chart of how we did in terms of completing our process measure or the number of education components that they completed. So after our initial PDSA cycle, where we had an average of 3 out of 5 being completed, we were able to see that majority of the patients completed all of the components with an average now going to 4.6. So we did well overall in terms of completion, but we did have these patients intermittently that you can see that did not complete the whole bundle. And in this Pareto chart, looking at what were the components or what were the missed elements in the pathway, the majority of missed elements were G-tube videos. And we know that this is because the G-tube videos we have at this time are only in English. We don't have a way of giving them those videos in their own language. And so if the parent did not speak English, we automatically mark those videos as incomplete. We did try to make up for this by providing in-person interpreters for all of the detailed education steps. And so what we were able to see is overall, throughout the study period, parent scores for satisfaction and confidence were quite high, and they did not seem to show any change across time, but the mean completion was 14, with the maximum being 15. So it felt like a lot of the times when we called the parents after they went home, they just would tell us, yes, yes, everything is okay, we're happy, there's no problems. But when we looked at resource utilization, we learned that a lot of the families still needed help and still reached out for help. And this was not all bad because the majority of the resources or the most of the encounters were actually phone calls or messages on the app, which is what we taught them to do. We said if you had questions, you can reach out on the app. And maybe this then avoided unnecessary ER visits or office visits for the family. Even so, we did have a decent number of ER visits, so about one-third of the patients ended up going to the ER for G-tube related concerns. And one of the patients got readmitted to replace the G-tube that fell out. G-tube getting dislodged was quite high, with 5 out of the total of 33 patients having the G-tube falling out, and that can be quite a difficult situation for families at home. And so we realized that not only is this a medical complication we have to advise them about, but also make sure they know how to respond to it in the appropriate way after they went home. So to summarize, we designed this multimodal, multidisciplinary, and patient-centered education pathway where we had good completion overall and parent satisfaction remained high. We didn't really have a baseline to compare it with. Even so, we did see resource utilization being quite high. And oh, so sorry. We know that access to educational resources in this cohort was difficult because of language barriers, which is something we tried to make do with the interpreters. And then lastly, there were a few patients after going home that seemed to have challenges with weight gain. And so in these patients, we've seen that providing nutritional support early on or even at the time of discharge might improve that problem after going home. And that brings me to the end of the presentation, and I'll stop to see if there's any questions.